for many healthcare providers out there with a comment to say recommendation not given for pre-medicating with Tylenol or ibuprofen prior to vaccination, but okay to give post. Thank you.
Thank you. Dr. Middleman.
Hi, this is Amy Middleman representing Sam. I just want to put in a word to express Sam's enthusiastic support of the COVID vaccine for our adolescents in order to safely return them to really developmentally appropriate and necessary activities and to get them back in the game, so to speak. We also support the concomitant. I also feel we support the concomitant administration of vaccines. It's often hard to get adolescents in for multiple visits, and again, we don't really want to pull them out of activities that in which they're just starting to re-engage. So we're supportive and excited and look forward to the vote. So thank you.
Thank you very much. Dr. Schaffner.
Sorry, Jose, I must have left my hand up.
No need for apologies, sir. Simply going through the list again. Dr. Sanchez.
Thank you, Roberto. Overall, I am in favor of being able to co-administer these vaccines. I would also add that it's not just whether the patient is behind or at risk of being behind, but also I would add to the importance of, to also weigh the importance of administration of that other vaccine as well. So if it's in a situation, it's not just because they're going to be behind if you don't give it or that the patient is behind, but that the importance of that other vaccine being given without delay. So because those situations do come up. But I also just want to really reemphasize the fact that it's not just reactogenicity, but it's also immunogenicity that really both need to be studied. And I certainly hope that those studies can be done and will be done. Thank you.
Thank you. Dr. Cotton.
Camille Cotton, I want to express my appreciation for this change in the recommendations. I routinely see many patients who are in the process of undergoing organ transplant evaluation, and the recommendation for the 14-day delay, which has ended up being weeks and weeks of delay, has really been a big stumbling block to providing appropriate vaccine-related protection to transplant patients. For over 15 years, I have routinely given up to half a dozen vaccines at any one clinic visit. So having this barrier to vaccination has really been an impediment. So I'm really appreciative of the change. My two suggestions would be, I think co-administration within 14 days is confusing. I don't think it's co-administration. It's co-administration if it's on the same day. So in bullet point 1, I might remove the co in the last few words. And then I might spell out what adjuvanted vaccines, because as someone who gets a tremendous number of questions about vaccines within my hospital, people don't really know off the top of their head which ones are adjuvanted or not. So I might just include in parentheses examples of adjuvanted vaccines. And thanks again for your adaptation of this, because this will be, I think will have a tremendous impact. I've also seen people kind of make up some additional guidance on that 2 weeks for other vaccines because they thought it worked for COVID vaccines. So they've kind of adapted it to Pneumovax and whatnot, which is really not appropriate. So I think it's really a good time for a change. Thank you.
Thank you for that comment, or those comments. So we're going to take two more comments, one from Dr. Bernstein and then the other from Dr. Howell, and then close this session and then move on to the next phase, which is the vote, motioning a vote for the Pfizer vaccine. So let me begin with Dr. Bernstein.
Thank you, Dr. Romero. I have a non-co-administration question, if that's okay.
Yes, of course.
So someone who has SARS-CoV-2 infection, whether symptomatic or asymptomatic, is less likely to be reinfected within 90 days. So given the risk of MIS-C in 12 to 17-year-olds who are often asymptomatic, are there any specific additional considerations for the timing of when they should receive a COVID-19 vaccine after having a positive PCR test? I wouldn't want the COVID vaccine to be thought of as contributing to the development of MIS-C.
This is Dr. Woodworth. I can answer that question. So the recommendation to delay for 90 days, as I mentioned before, was specific to patients who are diagnosed with MIS-C, and there are not recommendations to delay vaccination for individuals who have an acute COVID-19 infection. And so right now that would include adolescents, and that's really to prevent sort of missed opportunities for vaccination in this population.
I just wouldn't want those that develop MIS-C to be interpreted that it was related to receipt of the vaccine.
Thank you. Dr. Howell.
Hi, thank you. Molly Howell with the Association of Immunization Managers, representing the 64 awardees who are implementing COVID vaccine and other vaccines around the country. And from a programmatic perspective, obviously, we would be supportive of co-administration. I think over the summer months, there would be a lot of missed opportunities with high school activity physicals and other back-to-school immunizations if we don't give COVID vaccine at the same time as other vaccines. And in the third bullet, something else to consider would be school requirements. And so deciding whether or not to co-administer with COVID vaccines. Many states have school requirements for different adolescent vaccines, and that might be a considered addition. Thank you.
Thank you. So that ends this session. So we'll go ahead now, and I'm going to ask Dr. Oliver to put the question for consideration up on the screen. Okay, so I'm going to read the policy question. I will need a motion and a second, and then we'll open it up for further discussion prior to the vote.
Dr. Romero, just to clarify, Dr. Oliver has about 2 slides. This is the policy question. The language for the vote is the next or the third slide.
I'm sorry, forgive me. Go ahead. Yes, you are correct. So the policy question is, should vaccination with Pfizer BioNTech COVID-19 vaccine, 2 doses IM, be recommended for persons 12 to 15 years of age under an emergency use authorization?
Do you want Dr. Oliver to take over, Dr. Romero?
Yeah, why don't you do that?
Thanks, Dr. Romero. Happy to. Was just going to remind the work group that the ACIP, that these were the summary of the work group interpretations that when considering the totality of the data, the balance of consequences were that the desirable consequences clearly outweigh the undesirable consequences, and that the proposal from the work group to ACIP is to recommend the intervention. Next slide. And this was the vote language proposed, that the Pfizer BioNTech COVID-19 vaccine is recommended for persons 12 to 15 years of age in the U.S. population under the FDA's emergency use authorization.
Thank you very much, Dr. Oliver. May I please have a motion? Dr. Paling.
This is Kathy Paling, and I would like to move to approve this motion.
Thank you very much. I have a second. I believe Ms. Bata has her hand up. Ms. Bata?
Yes, I second that motion.
Very good. Thank you very much. Now pertaining to the voting members only, are there any further discussion? Is there any further discussion on this topic?
And at this time, thanks, Dr. Alt. Please turn on your cameras, ACIP members, for final discussion and vote. And we're going to update the webcast. And I'll also, as we're doing this, I'll also remind the ACIP members to restate any conflicts of interest, or if you have no conflicts of interest, as well as at the end of the vote, if anybody would like to make a comment about their vote, we will allow time for that. We also, Dr. Romero, I think we are almost ready. Ready?
No, I'm looking, I'm just going to move chairs here. Okay. All right. Very good. Let's move forward. Is there need for any further discussion? Not seeing any or hearing any, then I'll begin with the vote as stated by, I'm sorry, did somebody have something to say? Okay. Again, as Dr. Cohen said, state if you have any conflicts of interest. So I'll begin and proceed alphabetically. Dr. Alt.
Alt, no conflicts, yes.
Dr. Ms. Bata.
Bata, yes, no conflicts.
Dr. Bell.
Bell, yes. No conflicts.
Dr. Bernstein.
Bernstein, yes, no conflicts.
Dr. Chen.
Chen, yes, no conflicts.
Dr. Daly.
Daly, yes, no conflicts.
Dr. Fry.
I'm not sure if I'm supposed to vote, Dr. Romero.
You can say that you recuse yourself.
Recuse yourself.
I recuse,
yes.
Fry recuse.
Thank you, Dr. Fry. Dr. Cotton.
Camille Cotton, yes, no conflicts.
Dr. Lee.
Lee, yes, no conflicts.
Dr. Long.
Sarah Long, no conflict, yes.
Ms. McNally.
McNally, yes, no conflicts.
Dr. Paling.
Paling, yes, no conflicts.
Dr. Sanchez.
Sanchez, yes, no conflict.
Dr. Talbot.
Talbot, no conflict, and yes.
Romero, no conflicts, and yes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Yay, and 1 recusal. The motion passes. Dr. Cohen, any comments from the group? Dr. Talbot, your hand is up first. I'm sorry, go ahead.
No, I just wanted to say that the vote, I have the same vote count, 14 yeses, 0 noes, and the motion passes. So we can go to comment.
Okay, very good. Dr. Talbot.
I just want to say how excited I am. This will mean that the rest of my family can be vaccinated. That's a little selfish because I know we have less than 12 years of age to go, but just to set an example, my husband and I are vaccinated. My 16-year-old is vaccinated, and now my 12 to 15-year-old will be in line, and I'm ever so thankful. So thank you.
Dr. Cotton.
Similarly, I'm very excited to have this vaccine approved for this age group. This is a really important issue for this summer. It's also a very good way to provide better community immunity, especially for immunocompromised patients who have these teenagers in their families, and this is another way to get closer to ending this horrible pandemic.
Thank you. Dr. Lee.
Thanks. I just wanted to make a comment because I think sometimes we lose the importance of children and adolescents in the midst of a pandemic. There's been such a focus on older adults in particular. I think that the childhood experience that our kids have gone through will have long-lasting consequences that may extend across generations, to be honest. We don't really fully yet understand the total health, mental health, physical health, mental health, and educational impact of the pandemic on our kids, and we know that there are already disparities in hospitalizations, disparities in MISC. And so I anticipate that with disparities in infection as well, that the consequences could be far more severe than we anticipate. And I really strongly, advocate for taking a life course approach to thinking about COVID and the impact of COVID for our generation and for generations to come. Thanks.
Thank you very much. Dr. Daly, please.
Yes, thanks so much. Two brief comments. One is U.S. focused, the other is global. In terms of U.S. focus, I think one thing we haven't talked about a little bit, but not a ton, is that there really have been 130 million doses of Pfizer vaccine given, and to date, the safety profile of that vaccine in use has been really positive. So, I think I want to remind everyone that the intensive safety scrutiny of this vaccine will continue after the authorization. We're just going to get more data about the 12 to 15-year-olds. And then the global comment is that, I think if we look at what's happening elsewhere in the world, that's evidence of what happens if you don't have adequate supplies of safe and effective vaccines. That is what happens. And so we're in this very privileged position where we can see declining deaths and declining case rates because of these vaccines. And so this is just another group that'll be vaccinated that'll continue those downward trends. Thank you.
Thank you. Dr. Bernstein.
I just wanted to reiterate what everyone else is saying, that the benefits far outweigh the risks. I think this will provide protection for 12 to 15-year-olds. It'll decrease transmission within their families. It'll contribute to community immunity, and it'll allow the kids to more safely go back to camps this summer and back to in-person school. So I'm excited for the idea that 12 to 15-year-olds are eligible for vaccine.
Dr. Paling.
I want to reiterate the importance of this vaccine for the teenage children themselves. COVID-19 hospitalizations are increasing in children, with over 13,000 hospitalizations. Children in April 2021 comprised 9% of all cases, and that's even higher than those 65 years of age and older. Children can have severe disease from COVID-19 infection themselves, as well as from MISC. Long-term implications of COVID-19 can be very significant. For example, we had a teenager who presented with a heart attack with their COVID-19 illness, and fortunately did survive, but that will have long-lasting impact. While deaths are uncommon in children, COVID-19 deaths are one of the top 10 causes of death for children. Many children have underlying conditions putting them at increased risk. COVID-19 vaccine is both safe and effective. Many parents and adolescents want to be protected by being vaccinated, and I'm so glad we have the vote to enable them to do that today. Thank you.
Are there any other comments from the voting members? So let me just say that this is one more step closer to attaining immunity and bringing the pandemic closer to the end. We still have the younger age group to deal with, and we are dealing with that. And we still need to vaccinate the rest of the world. But we've made significant steps and are on the road. And as usual, I want to thank all of you, all of the voting members, the liaisons, the ex officios, for all the time and work that you've spent and dedicated to this effort. This is now our 15th meeting this year. That would translate to roughly 5 years of work in a single year. So again, thank you. It does not go unnoticed and unappreciated. So thank you very, very much, and good work to all of you. So we'll move on to the final session after we take a 5-minute break. so you can stretch your legs, get something to drink, and we'll be back at 20 after the hour. Thank you very much. And you can close your cameras if you wish.